is, I believe, the only emergency medicine practicing in Kenya. Daktari, how are you?
Fine, thank you. We actually now have Dr. Moseti at Nairobi Hospital, so now we are two.
Oh yes. It's a growing community, and
Yes.
it will become more and more. The more, the merrier. You are also the founder of the Emergency Medical Foundation, and he's also the previous president of the African Federation of Emergency Care. So, Dr. Wachira, welcome to today's session. We usually like starting exactly at 2:05, and you may take us away.
All right, thank you very much, Amina. I will just start sharing my screen. Let me just put that up. Sorry, just give me a second. I'm looking at where we are at, where we potentially should be, and where we need to be going. So the presentation has a lot of factual information that some viewers may find sensitive. So I will warn you before playing any of the videos. So this is just an introduction to this presentation. Some of you may have seen this video before, but for those who have not really seen it, then this should give you a good idea where we are starting from. Let me just optimize this.
Ngoja. Sijapata mtu kunihudumia. Madam, nagairia mtoto. Tafadhali nisaidie. Nisaidie mtoto wangu.
Rudi kwa laini. Nimesema urudi kwa laini. Kama utaweza enda private.
Lakini iko mbali sana. Na utanipisha pesa nyingi.
Basi rudi kwa laini.
Tafadhali.
Nimesema urudi kwa laini.
Kwa haraka, kwa juzi, enda private.
Hello John. Ni Vincent. Nahitaji kalori.
All right. So while that may easily have been, it was an enactment of a scenario that has been witnessed in many facilities across the country, but it continues to exist as a scenario for access to emergency care in the country. The obvious things, of course, that came in from the presentation from that short video was Number one, most people do take themselves to hospital because they do not have access. We don't have access to ambulances, public ambulances. Number two is many facilities are not necessarily designed, were not designed as emergency centers or as emergency departments. Most of them were designed as outpatient departments where clinics and stable patients are seen, and thus lack the appropriate mechanisms for things like triage and what would constitute an appropriate emergency department. So my presentation today essentially is looking at the recommendation by the WHO. So it's the Emergency Care Systems Framework that was adopted in the 72nd World Health Assembly by member states, which Kenya is part of, that looks at the complete picture from when someone gets acutely ill or injured or involved in an accident. How do they access an ambulance service? How does the ambulance manage the patient? And then where does the patient take this patient? Where does the ambulance take the patient to? And of course, going all the way into the facility where they get received, they get triaged, they get provided with emergency medical treatment, and finally, there is disposition, whether they get admitted to a critical care unit or get discharged home or get transferred to another hospital. And I think the whole emergency care system framework has come to the forefront with the current COVID-19 pandemic, where you've had many discussions about people driving from hospital to hospital looking for beds for where they can get oxygen, or people dying trying to get to a hospital. So this is something that highlights significant gaps in emergency care services that ideally would have been there prior to the pandemic and still should be invested in, because it's very sad, and I'm sure many of you may have been in the situation where you're trying to find which hospital has an oxygen bed. Unless you're very conversant with the healthcare system within your locality, most of the time it's a trial and error, which is not necessarily supposed to be the situation. With a properly organized emergency care system, then you should be able to call for an ambulance, get the ambulance personnel would ideally know where the beds are available, and patients would be triaged accordingly. So we're going to go break this down into bits and pieces and look at what is ideal versus what we have in the country, and at the end of it all, look at where we are headed in terms of trying to make a change to strengthen the emergency care services. So the scene from the first picture essentially starts off with the bystander response. The bystander being any person who's next to either, so it could be you at home to a relative, or it could be on the roadside where there's an accident, or your neighbor, especially if you're a healthcare worker. Many of your neighbors know you are an emergency, you're a healthcare provider, regardless of whether you work in an emergency service or not, that you will always be the first point of contact. And in terms of bystander response, in our setting, the first bystander usually is untrained providers because there's not really much widespread knowledge of first aid. So most of the time it will be just a regular bystander. If you're on the road, that will probably be a border person who will be responding to you. And sometimes the bystanders, well, they may really want to be doing the right thing, they're not really trained. It's not really their responsibility to provide emergency care in the pre-hospital setting, but they're the ones available in most of our settings because we don't have the ambulance services available. Naturally, of course, they need to have access to an ambulance access number, and we'll discuss bits and pieces of this. And also, there's a dispatch center which then coordinates all the emergency services. So right now, if we had a properly established dispatch center, then people would not have to drive around looking for COVID-19 beds. So let's look at the bystander response. What do we normally see happen? Again, we will warn you, most of the videos are a bit graphic, so if just turn away if you are sensitive. So this is what we normally get as bystander response. Let me just play this.
Aende polepole, hata itaanguka tena. Na hauwezi kunja si maji zinaanguka. Gari itaanguka. Mwambie polepole. Polepole bana. Yaani hakuna firefighters wanaweza kuja na vitu wakate. Kenya mbovu Yaani Kenya ana. Unaona kama juu na jamaa analia. Hii ni kazi ya polisi wangeita. No, firefighters ndio ufanya hizi vitu. Singeangaita wangeita. Lakini hao wana control mbaya na jamaa juu anaumia sana.
So that video, the couple of things. So while many people assume emergency services are required by those who cannot afford healthcare services, the interesting part of that video was the patient was in a BMW and the accident happened right behind Nairobi Hospital. So in terms of access to good care, the patient potentially had access to good care, and the care was actually right across the door. But unfortunately, because we do not have an organized system in the country, it took the effort of bystanders, which is what they were trying to do to get the victim out and take him to the nearest hospital. Again, highlighting the fact that all of us are pretty much vulnerable to needing emergency care, and we will be at the mercy of bystanders when we have an emergency. And if you're not conscious enough to coordinate this, then that could potentially also, you may have survived the accident or the emergency, but may not survive the response you get. Which is, again, we've seen a lot in the situation, especially where people are trying to do, they can only do what they know is best, but do not know what is the right thing to do. So again, this is necessitated by the lack of an ambulance access number. Before COVID, we actually did not have any national public ambulance toll-free number. The 719 number that was initiated as part of the COVID response is the first medical emergency number we've had. People will always ask, what about 999? So 999 is a police number, it's a security number, and it's connected to the National Police Services, not to any ambulance service. And thus, most people, if you have an emergency, 719 is the first number we've ever had. Though while it was designed for COVID-19, the feedback anecdotally has been many people have been calling for all sorts of emergencies. And similarly, for those who may know of this initiative, the 1196 Wheels for Life, that was targeting pregnant women accessing emergency services during lockdown, which we're all back in now at the moment. And yes, the program is still running. So these are initiatives. So the first one was by government, this one was by private providers to try and provide emergency services for the general public. And they were all designed during this COVID period. But of course, even beyond COVID, there are patients who have emergencies on a daily basis, so they still remain untargeted. But looking at the data, this was April, May, June, July, like 4-month data from the Wheels for Life program. As you can see, in 4 months, they had received a total of over 10,000 calls and needing transportation for approximately 500 people in that given time, and medical advice required for close to 1,000 people in just 4 months. So And this, again, this is a very specific project that was targeting pregnant women. But you can imagine how many people every day would require to call an ambulance or would require emergency services. And if we had an EMS system, this would have been how many people would benefit from such. So, and ideally, an ambulance access number needs to be available 24/7, needs to be a single number. Of course, there needs to be public awareness of the number. Short code numbers are preferred, and toll-free numbers ideally would be. So this would be equivalent in the West. What you have is the 911 numbers or 112 in the European system. So we still don't have this. We still push and hope that the Ministry of Health will direct the 719 to exist even beyond COVID, and hopefully then that becomes our national ambulance access number. So again, this is some of the things we really are pushing and advocating for. So what we have so far are private ambulance services. So overall, there are multiple, over 1,000 ambulance companies and organizations and services, but they are not really well coordinated. And because everyone owns one or two ambulances and everyone has their own number that you can call them, and yes, they're not free. So what you have are the two. So rescue is like an Uber service for ambulances. So they've brought together multiple ambulance companies under a single platform. And so they have access to, I think, close to 1,000 ambulances across the country. Similarly, A+, which is Red Cross, has ambulances, I think over 300 ambulances scattered across the country. So these are the two coordinated ambulance services that are cross-cutting beyond counties and across the country. But in terms of number of ambulance companies, there are tons, but most of them are small and localized within specific localities. So it's always good to have an ambulance number that you can reach. So looking at transportation, so how do patients get to hospital? From the videos you've seen, bulk of the patients, this is again from previous studies we've done and similarly done also at Kenyatta, most of the patients get to hospital by their own means. I think Uber released a report a couple of years back showing that the number one destination was Aga Khan Hospital. Well, this may also include people who are coming to visit patients, but we also see patients being brought in by private vehicles. And again, anecdotally, if you speak to Uber drivers, they'll tell you a lot of times they've been transporting patients to get to hospitals. But even out beyond Nairobi, even within communities in the urban and rural settings across the country, the number one means of transport to hospital is by private means. So this ranges from taxis to tuk-tuks to public vehicles, public service vehicles, and also to borders. Again, I'll show you another video. Again, viewer discretion advice. So this is looking at how people do get to hospital. Let me just share. Yep, I got it.
Kuna mwingine hapo ndani? Kuna mwingine? Lakini kuna mwingine pelekeni kwanza huyu hospitali. Mpeleke hospitali huyo tatari. Mudu mpeleke haraka. Manu. Peleka fiki sasa. Wewe. Peleka Madereva ni uko alikuwa. Wewe tukainua tuone. Tuinua brother. Wewe tuinueni.
All right. Again, let me just put that. So yes, as you can see, this is what we see on the road. This is what actually happens. Most of these video clips normally start circulating there on social media channels, and that's where we picked them up from, and just demonstrates what not having an emergency care system in the country leads to, and potentially many people would have survived over the last couple of years had we developed one of the systems. So while the question exists in terms of, do we have the appropriate policies, or what is an ambulance? So KEBS actually released KEBS standards for ambulances, and all ambulances are supposed to be adhering to these standards. They were released in 2019 that detail what exactly is an ambulance, what should be in an ambulance, and ambulances are no longer just any vehicle where you buy a van and put a siren and call it an ambulance. So there are specific guidelines, and organizations and facilities that run ambulances should be adhering to the KEBS ambulance standards. So in the standards, they define what are the minimum requirements in terms of vehicle design. So you don't just buy a pickup, or you don't just buy a bicycle and call it an ambulance. So there are specifications in terms of vehicle design, who should be working in the ambulance again. So it's not previously just whoever was in a matatu before, now is the one working in the ambulance. And of course, what medical devices. So many people still, because it's not something that has been commonly in our system, many people grapple with the idea of an ambulance is actually a mobile emergency department with providers who are trained to the potential knowledge and skills for even those working in the emergency department. So only they provide the care in a pre-hospital setting. A lot of times, many people would think, why should I call an ambulance? Yet I can drive myself to hospital. So the care provided in an emergency department can be provided, and even in certain critical care settings, can be provided by ambulance crew in your house, wherever you are at. So the idea behind a ambulance service and EMS is care should be directed to patients, not patients seeking the care. And with proper systems, then patients will get even ICU care by the roadside or in their houses or in their neighborhoods. And this comes from having a developed system. In terms of ambulance personnel, so most ambulances ideally should have two personnel, one being an operator. They're specifically called ambulance operators, not drivers, because they do, especially in certain ambulances, require to have training as drivers for ambulances, but also training to provide emergency medical care, at least to an EMT or paramedic level. And then you have EMTs or paramedics. So again, there are KEBS standards for this. There are KEBS standards for this, which look at, especially if where the ambulance operator is involved, is the minimum local requirements to drive, qualifications to drive, pre-checks, response mode, vehicle operations and scene and post-run checks. What we've seen a lot, and if you've ever seen, we've seen situations where ambulances have head-on collisions with other vehicles, and both the ambulance crew and the patient they were transporting all die on scene. And a lot of this has been potentially because we do not hire trained professionals to drive the ambulances. And interesting enough, if someone knows, an ambulance costs like 10 million shillings, a fully equipped one. And we've written off a lot of ambulances purely because we think anyone with a driving license should be allowed to drive an ambulance, which is not necessarily true. And this needs to be properly regulated to ensure that we're not having not in a bad way, ex-PSV drivers, let me use that word, ex-PSV drivers driving ambulances. These are two different vehicles and serving two different purposes. And while speed is necessary for both, safety is also important for both the patient and the crew involved. Similarly, you have, in terms of pre-hospital medical care, so still part of the treatment. So EMTs or emergency medical technicians who work behind an ambulance are trained certified pre-hospital healthcare providers and provide patient care on scene during transportation to the emergency center, and in many situations will actually save your life. where you're having a life-threatening emergency, and this is based on their training. So there are two curriculums that have been in use since the 98 bombing that have been used to train EMT providers across the country. These two curriculums, one is by the Kenya Council of Emergency Medical Technicians, and the other one is by Kenya Red Cross. And we did an assessment looking at what would be the best modality, or what are the recommendations that need to improve the training for EMT providers. And I can tell you, over the since 1998, there are over 1,000 EMTs trained, which is still a small number compared to the demand that ideally would be there. And in 2018, the Masinde Muliro University started a paramedic program, again, trying to address the gap that exists in the pre-hospital setting. So if we look at one of the biggest gaps we have, especially in pre-hospital care, is the lack of regulation and the lack of appropriate policies that control and regulate pre-hospital services, in the sense that we have a medical council for doctors, we have a clinical officers council for COs, nursing council for nurses, but we do not actually have any regulatory framework that has been put in place for EMTs. So yet they do provide medical treatment and they do provide medical care. This is one of the gaps that again, we've been trying to push for and advocate with the Ministry of Health, that they need to rope this in and provide clear guidelines and clear regulatory framework for these providers to ensure that, again, if medical care is being provided in a pre-hospital environment, then it should still be under the watchful eye of the Ministry of Health. So this is some data we did. So we did a national survey looking at emergency services. This is around 2018, 2019. So some of the data that I will be sharing in this presentation will be from 2018, 2019, when we did a national survey looking at emergency care services across the different counties. In total, I think we did capture 44 counties of the 47 counties, and got data from close to 200 facilities across the country. So in terms of how much number of people transferred from facilities for emergency medical treatment annually is like 23,000 people need transfers. Most of these transfers are not being done by ambulances. They're done by private vehicles on an annual basis. Only 10 counties. Remember, there was healthcare was devolved, and thus each county is responsible for its own healthcare. Like now here in Nairobi, NMS is responsible for healthcare. In Kiambu County, and Kiambu County government, and so on and so forth. So only 10 counties did report that they had an ambulance dispatch center. In total, there were 503 county ambulances. We did not necessarily evaluate to what extent they met the KEB standards, but they were labeled as just county ambulance. FBOs, NGOs had 58 ambulances. We didn't check how many private facilities had, how many ambulances were available in private facilities. As you can see, it's a very small numbers for a whole country, to covering a whole country. EMTs hired by the counties, only 111, which is a small workforce. From a cost perspective, average ambulance transportation cost was like 4,300. In the by county ambulances, but if we include FBO NGO ambulances, the cost moved up a bit, around approximately 5,125, and this is was mainly for county, for transportation within the county. Outside the county, then the costs definitely go up. If we're looking at how much is spent annually in terms of from the how much it costs annually to transport patients, it's close to 88 million shillings is used annually to transport, which averages approximately 2.4 million per county, which is still a very small amount of money considering the service is not widely available or widely accessible. But at the end of the day, so this is just in summarizing from pre-hospital care, at the end of the day, once emergency care has been initiated in the pre-hospital setting, then the patients ideally should be transferred to identified emergency care centers. So not one of the things that's a common misnomer is that every facility should be able to provide emergency care. This is actually not feasible from a financial resources human resource and very other resources perspective. So there is a need to designate which facilities are emergency centers and which ones are not.
Dr. Shira?
Hi, sorry. Yes, I lost. Yes, I think I'm back now.
Yeah, you're back.
Yes, all right. So, which are the emergency care centers across the country? So, this looking at the WHO emergency care frame, we look at emergency centers from a perspective of definition, location. Yes. Oh, sorry.
You're back, but you're not completely back.
Let's see. There, sorry. Yes, sorry about that.
Okay.
As a power side. So as I was mentioning, is that better, Amina?
Yes, now you're much better.
Okay. Yeah. So I was talking about emergency centers from the perspective of what exactly is an emergency. All right. What exactly is an emergency center? Where are they? What should be the equipment? What should be the staffing? What is triage? And of course, treatment. So by definition, this is looking at from the perspective of functionality and what essentially would constitute an emergency center. So, an ideal emergency center is a facility that has a dedicated emergency department, care is available 24 hours a day, 7 days a week, and has a functioning operating theater to allow both provision of providing care for, by definition, would constitute what is an emergency center. So, again, in 2018, 2019, we went countrywide to try and identify what are the public emergency care centers. This includes county facilities and what are these ones called? Faith-based and NGO facilities, county by county. And we're able to map out 198 public emergency centers across the country. Also identified 70 private emergency centers, which met that identified criteria, but we didn't map them out. But looking at what exactly let me just get open the web page so that we can see where these facilities are. So just open. All right. Sorry, the internet is each of the emergency centers. And let me just use this one here. And we're able to identify, by definition from WHO, everyone across the country should be able to access emergency and surgical services within 2 hours of an emergency. So that was the need for us to look at what exactly are geo positions. And so majority of them were level 4, 5, and 6 facilities. I don't think we identified any level 3 facility. And we did a breakdown to see. So like now, this is the Sierra level 4. I don't know which county this is. We did this work with Google, which helped us also develop websites for the different facilities. So you're able to get some information about the facilities. So let me just go slideshow. Yeah. So we did, and the map is available online. You're able to look at the different emergency care centers across the country. So one of the things, so we did an analysis using some WHO tools to look at what is, when we say it's an emergency center, what are the capacity, what are the capabilities of this facility? facilities. And ideally, most of them handle, as you can see, close to 2 million adults, because most of them do not have a designated emergency department. So some had outpatient, some had an emergency department, and the data wasn't well collected to tell who's who. So, but you can see approximately 8.5 million adults visit emergency centers annually, 2.4 million kids visit emergency centers annually. Majority of the facilities you can see annually they do transfer 16,000 patients to other facilities and adults and 6,500 kids get into other facilities. Equipment perspective, look like that one is even where I work doesn't meet all these criteria, but there are some basic equipment that's been recommended by the WHO. And the discussions you're hearing now about oxygen and oxygen tanks, I can tell you of the facilities, one key majority did not have any piping in the emergency departments. The discussion that we have about oxygen is because most of the facilities provide one oxygen tank. Then you are in the middle of a pandemic. Sure, that was identified. But most did not have any piped oxygen. See, less than 50% had a death, which patients and those who are busy dying, all of you know. As you can see, even then, oxygen supply, 30% of these facilities, and these are the facilities, remember, these are the emergency centers. 30%. Go ahead. Amina.
Yes, I'm losing.
Hello.
Yes, Dr. You're breaking a lot. So
hello.
Yes, Dr. Washira. Benjamin.
Oh, sorry.
Yeah, your internet is breaking a lot.
Yes.
Yes.
Oh, sorry about that. Is that better?
I believe it is.
Hello. Yeah.
Yes, I can hear you much better now.
Okay, let's hopefully it stabilizes. So yeah, so I was looking, so I was talking about the infrastructure. As you can see, one of the things, so two things were glaring problems from our assessment. Number one was oxygen. The biggest second problem was blood. Only 40% actually had a blood bank or ability to transfuse blood. And so even if emergency showed up there, they don't have access to blood. We're looking at, so if we were to combine all this infrastructure, only 20% of the facilities could actually had all this available in their setting. So the other thing we're looking at is, again, availability of emergency care equipment. As you can see, oxygen saturation monitors, your pulse ox, again, less than 50% of these facilities had a pulse oximeter. Cardiac monitor, less than, only 32% of them had this. ECG machine, especially that was key because there's a huge rise of NCDs and only 25% of the facilities and had ECG machines. So availability of all this equipment in one facility, only 16% of the facilities had this equipment. Looking at staffing, ideally, most EDs had rotational staff where the staff could be from maternity, or the nurse was at CCC last week, is the one now in the emergency department. So most of them do not necessarily have trained staff to handle the emergencies, and there is a requirement that emergency departments need to have permanent staff, non-rotational staff, with at least basic triage training in triage, adult medical emergency care, pediatric medical emergency care, obstetric emergency care, and trauma care. This was most of the emergency centers across the country manned by by clinical officers. Very few actually had medical officers working in the emergency department and nurses. So as a cadre, there's a need for these facilities to really invest in upgrading existing staff to handle different emergencies. When you look at triage, triage is the one big thing that we'll always highlight in terms of emergency care, especially from the perspective that the emergency department is not a fast come, fast serve space. And there needs to be a process, from the video I shared initially, there needs to be a process where patients who are having life-threatening emergencies are prioritized compared to those who may not have life-threatening emergencies. And this again needs to be known by everyone, including those who are waiting, so that people don't think mheshimiwa amerukishwa line or such tendencies. So most facilities again do not have any triage process in place, and that's why even the video that we showed at the beginning of the presentation essentially showed what happens. And I think from the multiple media reports where you've had people dying waiting to be seen by a doctor or dying in the emergency department essentially highlight a gap in availability of a triage system in the emergency department. In terms of treatment, so as you can see, less than 50% of the facilities had triage guidelines. So again, which we also identified, most of them also do not have emergency care treatment guidelines. And again, this was a significant gap. Less than a quarter of them had this. That did not have any of this, all the guidelines available, which again is easily evident from the gap we see in the care. In terms of how to do some procedures, in terms of resuscitation with advanced life support measures, only 40% of the facilities could provide this. Intubation, so right now, majority of the COVID-19 patients potentially need intubation. I can tell you only 21% of the facilities have this capacity. We didn't even go into ventilation, just basic care management. Similarly for pediatrics, dismal in terms of capacity. From a trauma perspective, we looked at things like chest tube insertion for thoracic trauma, and again, majority of the facilities could not insert chest tubes across the country. And then availability of all these procedures, only 12% of the facilities had all these services available. But one of the criteria for the emergency centers was availability of surgical services or a functional operating theatre, let me put it that way. So cesarean section was available in majority of the facilities, laparotomy in a smaller number, management of open fractures, only 6% of the facility of all these three services. So these three services are specifically, they're called bellwether procedures as defined by the WHO. So the bellwether procedures are like the minimum surgical capacity some of these facilities, a facility should have. So cesarean section, laparotomy, and treatment of open fractures are like indicators identifying the availability of surgical services at a facility. So only 57% of the facilities did meet these three criteria. So in terms of treatment guidelines, so there's no nationally available treatment guidelines from the Ministry of Health around emergency care. What we have are those that the Emergency Medicine Kenya Foundation have been releasing for the last 5 years. And these have been disseminated as much as possible across the country and affiliate downloadable for use in emergency centers as a guide to providing emergency care within the country. And we are working with the Ministry of Health to see if we can have them now transformed to become national guidelines. So overall, that gives you a snapshot view of emergency care services across the country to as of now, and where things are, looking at it from the pre-hospital perspective through transportation of patients and facilities. And yes, it may look like a very sad picture, but there are, in my next part of the presentation, I will highlight some of the initiatives and some of the steps that have been put in place to try and start addressing some of this. I want to ask, do you want me to take some questions now or finish the presentation and then take questions?
Let's just finish the presentation, then we do the Q&A.
All right. So so that's the situation, but then what is being done or what can be done? Oh, sorry, I even missed out one part of the presentation. This looks at the costs, again, from that study, how much it costs to get emergency medical care. This is mainly, again, at public hospitals. So an average cost 1,128. And it's a different cost for different services across the country based on the data we collected at that point. So I will put this together to show you where things should be or where things can be. Let me share this. Sorry.
Every day around the world, millions of people need emergency care. People seek care for infections and injuries, heart attacks and strokes, asthma or complications during pregnancy. An organized and integrated emergency care system gets care to people and people to care. Timely emergency care saves lives. When an emergency occurs, bystanders are essential to provide first aid until professional care is available. Bystanders need 1. To be able to call for help, ideally through a universal access number. 2. To know the basics of first aid to safely assist the ill and injured. And 3. To be protected by a good Samaritan law. Universal access numbers allow bystanders to activate the system so that trained pre-hospital providers can be dispatched. Once at the scene, these providers can rapidly assess and stabilize the patient for transport. Using specific protocols, they identify the destination hospital that can best provide the needed care. During transport, the patient's condition is continuously monitored and interventions are performed. Ambulances always need at least 2 personnel, 1 to monitor and manage the patient during transport and another to drive. An ambulance personnel should be able to communicate with the hospital prior to arrival if needed. At the hospital during handover, the ambulance provider quickly gives critical information to hospital personnel. As patients arrive, they are triaged to different areas to ensure that life-threatening conditions are recognized and that all patients receive the care they need when they need it. Triage is done by assigning patients to categories based on acuity of their conditions. Some patients need to be seen immediately, while other patients may safely wait. Trained personnel use clear protocols and specific equipment to assess and manage patients. After initial care is provided in the emergency unit, patients might be admitted to other hospital units for further inpatient care, transferred to another facility, or discharged home after treatment. An effective emergency care system needs laws and regulations, protocols to guide hospital personnel, certifications to ensure compliance with standards, and processes for accreditation of the quality and safety of the services provided. There are several standard indicators that can be used to evaluate the performance of an emergency care system. These might include, for example, time intervals between key actions or clinical outcomes. This short video summarizes the following essential functions recommended by WHO for an emergency care system. These components can be implemented in every country in different ways depending on available resources. To learn more about WHO's tools for strengthening emergency care systems in countries, visit the WHO Emergency Care website. Remember, timely emergency care saves lives.
All right. So this next part of the presentation essentially is looking at what so far has been done, especially through the Ministry of Health, and potentially what are the things that we need to still work on to ensure a functioning emergency medical care system in the country. So last year, the Ministry of Health released the Kenyan Emergency Medical Care Policy 2020-2030 that essentially was developed over the last couple of years around the same emergency care system framework. And the idea behind the policy is to provide guidance for both national and county governments on how to develop their own emergency care systems. And we've been working with different county governments to see how best we can strengthen emergency care services county by county. So vision, of course, is universal access to higher standard of emergency medical care across the country. Mission, of course, standardization, regulation, coordination, and development of an emergency medical care system across the country. But again, this presentation was being made for the counties, so in the different counties. And I know UHC is still to be launched officially across the country, but one of the things that's part of UHC is access to emergency medical care services. The objective from the policies map out emergency departments. Some of this we've already done, and strengthen them to adhere to minimum national standards, ambulance services, and of course adherence to national standards. And then establish an emergency operations and ambulance dispatch center at a national level. This is where we are hoping that the 719 number can be retained to allow this to be, again, the access number, to allow this to be a national emergency ambulance access number for the country. In terms of objective 2, objective 2, in terms of quality service delivery, of course, strengthen capacity for integrated emergency medical care management, implement SOPs for ambulances and emergency departments, treatment guidelines both for pre-hospital and in-hospital emergency departments, and of course, enhance standards for health products and technologies, ensure the appropriate equipment is available at pre-hospital setting and also in the ambulances and also in the emergency department. Financing, big gap, again, resource mobilization for emergency services, and UHC has this part of it, has included part of this if it is released in the last format I saw it. There is a treatment fund that was established by the Health Act 2017, and this needs to trickle down all the way into the county budgets. And then the treatment fund established at the national government level needs to be administered in a way that will ensure patients have access to emergency medical services regardless of ability to pay, which is envisioned in the Constitution 2010 and the Health Act 2017. Looking at workforce, there's a need to ensure adequate emergency care workforce at all levels, so pre-hospital all the way into the hospital system. So not just hazard, making it guesswork as to who handles emergencies. Similarly, as the way we always use this analogy, because if you go to a hospital, the sickest patients are usually either in critical care units or in the emergency department. Yet we will push to have trained providers in the critical care unit and have the least qualified providers in the emergency department. That really doesn't work appropriately. There's need to implement emergency medical training for especially all healthcare workers working in the emergency care setting on part of the system, including the pre-hospital system. Of course, M&D to ensure we are trying to make things better, surveillance systems, data collection, system surveys to make sure things are working, and there's still more research that needs to be done in the field of emergency medical care in Kenya, and hopefully this research, a lot of the research that we've been doing has helped us influence and inform policymakers on what would be the ideal next steps. In terms of leadership and governance, there's need to ensure these things, the governance and legislation in line with national and county mandates and core functions. Of course, intergovernmental coordination for emergency medical care, especially in areas where there's mass casualty incidents or potential terrorism incidents, where security comes involved, and of course, norms and standards for emergency medical care in the country. So, as I mentioned, this is my last slide. There has been the evolution of healthcare in the country since the new constitution came in place, and in certain counties, actually, they've done quite a significant job trying to improve the emergency medical care services. So this video highlights one of the counties, which is Machakos County, which has actually done quite a significant amount of work in their emergency services. And though, again, it may not necessarily be 100% perfect, but they're miles ahead of many counties. And what we need to see is a replication of similar efforts in all the 47 counties to ensure that we have access to emergency care across the country. Okay, so let's see, share this. Sorry, let me just put that properly.
County is one among other few counties in Kenya which have endorsed the Kenya Medical Care Policy 2020 to 2030, which seeks to establish a working emergency medical care. These are services that provide urgent pre-hospital treatment and stabilization for serious illness. The EMC, which is one of President Uhuru Kenyatta's plan on universal healthcare UHC, was released last year by the national government through the Ministry of Health, with the goal of reducing mortality rates in healthcare centers. Here's Mark Himondo with that report.
With accidents being part of our daily lives, a rise in morbidity and mortality rates has remained a matter of concern for decades in Kenya. The country has been experiencing an increasing number of mass casualty incidents ranging from collapse of buildings, flooding, road traffic accidents, among others. Due to lack of fast and convenient agencies, most of them end up losing their lives. It is with this reason that the national government, through the Ministry of Health, released the Kenya Medical Care Policy 2020-2030 in November last year, which seeks to establish emergency medical care as a key component of the healthcare system. Machakos County is one among other few counties in Kenya that have endorsed the system in a bid to reduce mortality rates. As explained by Emergency Medicine Kenya Foundation Executive Director Dr. Benjamin Washira, emergency medical service, also known as ambulance services, are emergency services that provide urgent pre-hospital treatment and stabilization for serious illness and injuries.
So the emergency care systems framework essentially looks at what happens when someone falls acutely ill or injured. And it starts with, first of all, the bystander response, where the community supports the person and who's having an emergency. And then they make a phone call to a designated dispatch center. So the phone call, the numbers should be short numbers. You know, the way 999 works, and even now when Ministry of Health put in 719. So they make that phone call. And at the dispatch center, there are trained providers who then are able to understand what is the emergency, provide instructions for the person calling on what to do as they send the ambulance to your location. So the dispatch center allows them to see where you are, which is the nearest ambulance, and which is the nearest facility that is best to send you when you based on the emergency that you're having.
This is one of the dispatch centers in Machakos County, where people make calls seeking for emergency medical care services.
Metro Machakos, my name is John Mukunga. How can I help you?
This is a clinical officer trying to communicate with someone who claims to have been involved in an emergency.
If there is a road traffic accident, the public, they are aware of the numbers they are able to call, and when they call, the dispatch officers who sit in this room, they are able to know the nearest ambulance and the nearest health facility for that matter. So, for instance, if somebody says he has a road traffic accident or he has been involved in a road traffic accident along Mombasa Road, we have a standby ambulance in the junction there. And the guys who sit here, they have the contacts of the ambulance crew at that place. So they will dispatch them, they will tell them, okay, there's a lot of traffic accident along Mombasa Road, near maybe Mto Amawe. They'll give a direction and they give a contact number for the person who was calling. Then the guys, once they dispatch, they go, they take that casualties. Once they rescue the casualties, they bring them to Machakos Level 5.
Now, this is the CCTV control room, and one of the most important parts in this particular dispatch center, it's where the roads are, of course, monitored to give a view of what's happening outside there.
Have CCTV control rooms in all our sub-counties, and this is just one of them. This specifically for this control room, we house CCTV images from cameras located in Machakos town, Machakos Stadium, and from Chumbi to Machakos town. That is the highway. We do work closely with the security agents, that is mainly Kenya Police, the CID, when they need CCTV footage and there are investigations that are ongoing, we are able to provide images.
In this particular video, a lorry driver is seen reversing recklessly. In a few seconds, he knocks a pole, which falls and knocks a person. People are then seen converging at the scene of the accident, with the lorry disappearing unnoticed, leaving the victim nursing serious injuries. In a nick of time, an ambulance reaches at the scene and picks the victim. The incident shows how the system operates.
According to the statistics, like the most cases we receive like on daily basis, there are road traffic accidents, and then there are those mother in labor. Actually, ideally, when the government was purchasing the 70 ambulances, his idea was that no mother should deliver maybe on the way or at home. So the most cases we get are this mother in labor. When you go to our medical data there, you find that we have really very much reduced the maternal deaths.
Machakos Health and Emergency Services CEC, Dr. Ansend Kitoku Nzioke, says over 600,000 people have benefited from the initiative that has seen mortality rates in the county decrease.
We can be able to save so many lives because by the time they call the police or they call the ambulance, there is a lot they can do and they have been trying to do down there. And again, we know that sometimes with good intentions, bad outcomes come. And therefore, when we train these motorcycle riders and of course the rest of the population, that the do's and the don'ts at an accident scene, that is a big, to make a huge difference.
The dispatch center works hand in hand with Machakos Emergency Department Center, which is one of the largest casualties centers in the county. After being immobilized, a patient is then rushed in this emergency center where stabilization happens.
Any other patients, adults, we've divided from pediatric, medical patients, surgical, and all the emergency care is done. This is blood transfusion. The first initiation of management is to get to know the complaints of the patients. Then we check the history, do the physical exam, then initiates. We have a resident medical officer here who reviews the patient and gives the way forward for the plan or the care.
We have seven ambulances that are basic life support and 5 ambulances that are advanced life support, and they are functional.
The center, built in 2014, has 8 oxygen points and a minor theater to offer quick surgery services to victims who might need instant surgery after the accidents occur. Avoiding an accident can sometimes be a challenge. However, the next step taken after an accident has unfolded determines a lot on the survival probability of the victims of a particular accident. Being one of President Uhuru Kenyatta's plan in the universal health coverage, the initiative is expected to reduce mortality rate not only in this particular county, but of course in the whole country at large. Mark Kimondo for Hope TV.
All right. So
Machakos
that
County.
ends my presentation. So our hope, of course, is through working together with the Ministry of Health and the different county governments, then we over time will be able to develop an emergency care system framework that's specific to Kenya, that is operational and active and potentially save as many lives as possible in the different counties and of course nationally. Thank you. Yes, Amina, back to you.
Yeah, thank you. Thank you very much, Dr. Wachira. That was a very, very educative presentation. I've learned a lot. In fact, I didn't even know Machakos has 70 something ambulances and they are actively doing many good works. Thank you for raising awareness for that. I'll just ask a couple of questions online, and if you, for the people who want to speak, you can raise your hand. I unmute you. So number one, do we have a formal triage protocol in use in Kenyan public hospitals?
No, we do not have a formal triage protocol. What we are doing is different facilities have different triage protocols. So what we are trying to do is see if we can develop one that as a starting point. Of course, this will naturally need to be evolved over time as the system develops, but we hopefully will be releasing a draft. One that facilities, I know we've been doing a lot of triage for the different counties, triage training for different emergency centers. So we'll be releasing this and it will be available. Yes, but we don't have a national one, no.
Yeah, because most of the time people use the South African one or the Canadian one. I think you've gone to many counties. Which one is the most adopted?
The easier one to teach is the Canadian one. That's the one that is much easier because we normally have a limited time period to teach it. Teaching the South African one would take a longer duration of time.
Longer duration.
But yeah, but the main thing is it's not necessarily which specific criteria you use, whether you use the Canadian or the South African or the Manchester. You just need to have a system that is well thought through and available, that is used by the personnel working in the emergency department. So every facility can potentially develop. Ideally, it would be nice to have a national one, but the best thing is just have a system and make sure that system works. That's good enough as a starting point.
We hope we adopt a national one. That way it will be easier to communicate with each other. We just say, oh, this person is coded red, and we all know what red means and yellow means, and you know.
Yes, that would be nice.
Yes. Dr. Masasabi, I don't know if you'd want to say your comment. You can unmute and speak.
Yeah, thank you for giving this chance. Sorry, I have a little cold. But Benjamin, thanks for that great presentation. I think it is good that the next steps, I think we task the MOH to collaborate with you so that at least the first things we can start with, the toll-free numbers, which are easy to implement. And then I like that aspect of a coordinated platform for bringing together ambulances. That process had started, I think, in 2019, where Nairobi had been zoned. So I was just hoping that either Dr. Kibia Simon or one of his officers or Dr. Kuria would be here to give us a way forward, but hopefully we can reach out to them. I'll try to reach out to them so they can give us the way forward or the updates. Then I think we can link up. Another important thing, I think, which will loop in Dr. Kioko, is that regulation framework for the providers. I think it is something that had been raised by the EMT Council. I'm not sure that you are registered now as the EMT Council. I think it will be important that we follow up some of those issues. Otherwise, great presentation, Washira. Will support you despite my having moved to the academia from the ministry. Thank you.
Thank you very much, Dr. Masasabi.
Thank you, Dr. Masasabi. We hope you get well soon as well.
Thank you.
Yeah, today we're having a lot of people commenting on the great presentation. Dr. I think the video aspect has actually opened our eyes to many things. Please fire your questions on the question and answer panel so that we can be able to make it more engaging. Somebody mentioned something on the chat box regarding the ETATs for pediatrics. Is ETATs really a triad system, or is it like an emergency training for pediatrics?
So ETAT is emergency triage and treatment that's targeted at low and middle income country settings for pediatrics. So it's a good tool. So it's not it allows the healthcare provider to recognize a sick child. So it's not necessarily a triage guidelines, but it helps a provider quickly assess a child and identify the child that need emergency care.
Somebody also asked about where do people train for ambulance driving?
The easiest would be check with Kenya Red Cross and St. John Ambulance. They will be able to be directed from there.
So Dr. the first video, it really spoke to me. That scenario of people assuming that Triad has something to do with a queue. What are your suggestions, apart from having, of course, training people on what Triage is and everything of that sort? What are your suggestions in making it more efficient and effective from Triage?
So the first part of it is what you initially alluded to, is having a national triage system or just a triage system. But even with triage, one of the biggest gaps we've identified, and it's one of the projects we do, is availability of triage tools from the perspective of vital sign monitors or ability to take vital signs. So that has been one of the gaps that has been there, but we will, this year we're working on something, and hopefully we'll be able to share this and try and push for its adoption at various emergency centers that we work with. So for now, I can only just say, we're working on something. Hopefully we'll be able to develop something.
Yeah. For me, another thing that I would probably want to ask you on the forum, we are all at different capacities and we all have different abilities, but what would you advise us? What would you advise us? Sorry, let me unmute Isaac.
Yes.
Unmute him. What do you suggest we can do as humans to be able to assist you? I know you started the Emergency Medicine Care Foundation. What does it do? How is it helping? Can you enlighten us, and what role we can play? Because most of the audience here are healthcare workers, so maybe we can bring more awareness in that perspective.
I think the first part that we all can potentially play is go back to our facilities and figure out where the emergency department is, or whether it's an emergency department, a casualty, or an OPD. And now start looking at how best you can, how that department. So again, also get a free copy of the emergency medical care policy, and we will share a link with resources that you can download, which are available from our website. And look at the processes there. You can reach out to us for support on how we can help you at your facility improve your emergency care services. So I think that will be the first part. Defining what your emergency department is, looking at the processes that are there. How do patients come in? Are they being triaged? What treatment is being provided? Are the guidelines available? And these are the resources that we are able to provide through the foundation. Beyond that, of course, is then look at your HR perspective in who handles emergencies in your facility. One of the things that we normally don't necessarily want to think about is even us as healthcare providers will end up, sadly, sometimes in this emergency department. So is the person who's there trained to provide emergency care, or they will just let you there, or your relative? So it may not even be you, it may be your relative or your friend who ends up in the emergency department. So what is their level of training? Do they need additional training? Which training is available? How can we get them trained? And it's step by step. So step by step, and it's everyone's responsibility. Unlike many other problems in life, emergency care is one of the things that will touch you either personally or someone you love. And with this pandemic, that need is becoming more and more. And as healthcare providers, whether you're in surgery, whether you're in OBGYN or pediatrics, down the line, these patients do get to you, and those are the ones who actually survived the emergency care. So I think even as existing specialists should need to go back and look at the emergency department to ensure that patients who present with emergency conditions are being handled appropriately to give them a fighting chance to get to the specialist. So I think we all need to do our part, and this is mainly because we are the ones who will be using this system at some point. You or someone you love, friend, relative, will end up using one of the emergency care systems. So the hope is you've done your part to make sure it's working.
Thank you. A question here regarding where can nurses who are interested in emergency and trauma care learn? As in, I think you understand the question.
Yes, so there is actually emergency nursing training programs at Kenyatta National Hospital, and Nairobi Hospital has an emergency nursing training program. These are really great programs. They've been there for years, and the graduates for these programs do work in some of the private and public emergency centers. So I think that would be a good place to start. Of course, there's a need for other institutions to pick this up and increase the training capacity, because the demand definitely outstrips the supply.
Okay, and how about medical training? Where are we at as a nation? Are we having any master training in emergency in the country?
Yeah, so beyond the short courses at Aga Khan in 2016, we started a postgraduate diploma in collaboration with the College of Emergency Medicine of South Africa. So this is for medical officers, and it's an 18-month program, and been able to train 15 candidates since then. Other training programs available are also for clinical officers at Kijabe Mission Hospital, and KMTC now has a higher diploma for emergency and critical care for clinical officers. So what we lack, and we still are trying to work with different medical training institutions, is a master's level training program, like an MED program. So Aga Khan is working to potentially start one as soon as we finish on the approval process. But I think there's still a need for many other of these training institutions to start similar programs, because again, there's a need to have the properly trained staff. So for now, most of it is just the availability of short courses that we have developed to target specific emergency centers. But again, people should not feel that there is no hope because there's no training. A lot of the development of emergency care specialists, even across the world, started off with healthcare providers who work in an emergency department, working together to build the department and to build their knowledge and skill. So one of the things that we really fight against is the rotation of staff, so that if we do not rotate staff work in the emergency department and slowly start training and developing this staff, they may not have the postgraduate qualifications, but based on the short courses they've done, the knowledge and skills they've acquired over a period of time working in these departments, then they are as good as many specialists in many countries. So I think that's one of the things that we really need to push for, is to have permanent staff working in emergency centers, and then now empower this staff through regular training.
Yeah, I can't echo that.
Can I make a comment?
Yes, please, Prof. Nwati.
Yeah, just to highlight, ETAT training is both triage and treatment. And the program has been scaled up in Kenya and outside Kenya. And it has been evaluated, and it is hospitals that have trained people have reduced child mortality. So and the program, it was underpinned by observations of children coming in and dying in the emergency room waiting to be seen. So there's a triage component, and then there is a resuscitation component, and then treatment within the first 48 hours. We also have a fellowship in pediatric emergency and critical care out of the Department of Pediatrics and Child Health. And we are training in collaboration with the University of Washington, Seattle Children's Hospital. And we have several people a number of trainees who are about to graduate from the program. And I want to support the training, the higher level training of this emergency care. The first critical care specialist in KNH was a pediatric critical care. And within a very short time, we saw a reduction in mortality in the ICU, because that's the other areas people work in, and improvement of critical care services. So this is a very great initiative, and we should all be out to support it. The other observation I want to make is that the greatest weakness in our services is that people keep on migrating from one thing to the other, particularly the nursing staff and the levels of the medical officer. We need to specialize even at that level. That's the only way we'll retain institutional memory and get better at what we do. Thank you.
Thank you so much, Professor. It's true that the part of institutional memory, it needs to be reinforced, especially through building capacity of the people who are already in the department. I've noticed a comment from Justin. Justin, I don't know if you can be able to unmute and speak and give a comment. Justin is one of the emergency doctors who collaborates with us here in Kenyatta National Hospital. He's from University of North Carolina. Justin.
Hi, yeah, thank you. Well, my comment was just that I said thanks to Ben. I felt that was a really insightful and inspiring talk, and I think that Ben has his finger on the pulse of emergency medicine in Kenya, I think like nobody else. So I really appreciate to hear what's going on. So yeah, I totally agree. I think that was really a unique perspective. I hadn't heard that said specifically what Ben said about the need is to continue to have permanent staff in the emergency department. And I think that is so true. And I just, coming to Kenyatta for the past, I think 7 years or so, 6 years, I've just seen the development of emergency medicine there that's been happening, somewhat organically, and it has improved exponentially, I think, the emergency care. And I think largely because of the permanent staff. I mean, now you have, Dr. Sagut, Dr. Robai, who have been there, for a long time, and just continuing to bring their years of experience. And so you're not fighting the same battles with the same consultants. I mean, you still do in emergency medicine, but you can make progress that way. That the turnover of staff it's just that really can hurt a program. So I think that's this wonderful initial advice while the country's preparing to develop a great MED program. I think just really getting buy-in from the hospitals to really focus on permanent staff. I think that's awesome. So yeah, that's all I happen to say. Thanks.
Thank you, Justin. Now, since we all know in COVID era, Dr. Wachira, what's your comment on that? I'm sure you're dealing with so many people who are coming in and who need emergency services. What's your take on how best to handle that?
I think one of the biggest issues we are having with COVID patients, it's actually not their treatment. Their management is fairly straightforward in terms of either you need oxygen, don't need oxygen, you need it in this amount of quantities, whether you need a tube or not. So the biggest gap we have actually is a systems issue. Systems issue in the sense that everyone who is presenting with let's say shortness of breath for COVID will end up at Kenyatta Hospital, and Kenyatta Hospital is full. They don't have capacity, or then the patient and their relatives have to move. Oh, let's check this hospital. Let's check this hospital. So, and of course, Kenyatta and many emergency departments do not shut their doors because we are full. I'm still to see that happen, at least in our setting. So more patients will keep presenting without having that understanding that there is no capacity, and the patients suffer not so. The patient is suffering from the disease, which is sad, but also the patients and the relatives suffer because they've become now shopping for hospitals, yet that's not necessarily their responsibility. If that's one of the things that, if Ministry of Health would just take up, improve 719, that if you are having shortness of breath, you call 719, and facilities provide 719 with information on bed capacity. So that means if you call, then either they get you an ambulance, but 719 will also be telling you, go to this hospital because this is the hospital with the beds. So a bed management system at county level and at national level, and this is normally done by a proper EMS service, would be really helpful for COVID right now, because what we are dealing with is a situation where the demand potentially outstrips the supply, but also there's a poor utilization of the supply because people don't know where the supply is at a particular time. So if all ICU beds are full now, one may open up in Kitengela in the next hour. But how am I supposed to know that bed is available in Kitengela? So my plea would be, it's not about the management of the patients in terms of treatment, because that's fairly straightforward. What we are having a problem is a systems issue that needs to really be addressed at a national, county, and national level, so that we can facilitate the appropriate movement of patients. So we can make sure patients are going to where the resources are rather than shopping around looking for resources.
Yeah, and you're right. It's really a system problem. In fact, that one bed in Kitengela might be available, and 10 people have been told, and they all go there. Those scenarios are very, very common. Probably, I think I had you say most of the facilities don't have pulse oximeters. What's your advice there? How do you think we can handle that? How do you think we can?
Yeah, so pulse oximeters, piped oxygen, vital sign monitors, these are gaps that have existed from before. And while the drive has been to, initially when the project, when the whole pandemic started, the drive was to get ventilators. I'm not sure why, but basic equipment, majority of the patients need basic equipment. They need, we need to increase our oxygen delivery systems by ensuring piped oxygen in many of these facilities. I saw a lot of isolation centers that were formed with just a bed but no piped oxygen, so that can't work. And then from a perspective of equipment, one ventilator can probably buy 10,000 pulse oximeters. So it's just a prioritization of resources to looking at what is immediately required versus what is required by majority of the patients versus what is required for a few patients. Yes, ventilators are important, but majority of the patients don't need a ventilator. They need a pulse oximeter to know that their oxygen levels are low, but also proper oxygen delivery, just basic oxygen. So it's looking at what are the resources being required by majority of the patients. Because in any emergency situation, even in a pandemic situation, you want to do the most for the most. And most of our patients just require the basic resources.
Yeah, I couldn't echo that more. Maybe just an observation in public hospitals. I sometimes I don't think it's a very good idea buying those small pulse oximeters, because it will be run down. It will not work in 2 days or 1 week, and the sustainability of it doesn't even make any sense. But the vital sign monitor, for those of you who are in a position to probably donate in such hospitals, or just you're in management in those hospitals, please prioritize such things. They last longer. I think we've reached 3:32 now. If you have any parting message, Dr.
I just want to say a big thank you to the organizers of this webinar. I think we need to have more of this discussing, of course, emergency care and different other healthcare needs of the country, but also my appeal would be to the audience to take it upon themselves to gain from these presentations, and also look at how they can support the strengthening of systems in the country. translate the knowledge they've gained from this into actual practice wherever they are. And hopefully, if everyone who works in a facility can go back and try and see what they can do for the emergency department and try and put in place measures, then I think we can support the government in strengthening emergency care services. As always, the Emergency Medicine Kenya Foundation is always available. You can just drop us an email, emkf@emkfoundation.org, and we will try as much as possible to provide as much support as we can. Thank you.
Thank you. Dr. Wachira also hosts a series of webinars. I think it's after every last Saturday of every month on his emergency care platform. We are going to have a series this week on emergency care. So tomorrow it will be international perspective and best practices in emergency care. It's going to be done by Dr. Austin and Dr. Lee. And on Thursday, we're going to have a session on state of emergency care at KNH by Dr. Sugut and Dr. Rubai. Thank you for listening in. Tonight, we're going to have also a webinar on, we're just continuing the series on SGBV violence, lessons learned by Dr. Wafula, Susan, and Dr. Margaret. Thank you very much for joining in. Dr. Wachira, thank you very much for your very interactive and educative presentation. We hope we can have another session in the future.
Not a problem. Thanks, Amina.
Thank you. Good day. Have a lovely day, people. I'll see you in the evening.
Bye.